Welcome to Unit 11, Neonatal and Obstetrical Transfusion Practice. The clinical laboratory continues to play a major role in the diagnosis of hemolytic disease of the fetus and newborn. The results of laboratory tests will assist the physician in deciding upon treatment options, which may include moderate to very aggressive therapy, including transfusion support both in utero, while the baby's in the mom, and or after birth. The transfusion service must be aware of the lab results, which indicate the severity of the disease, as well as the unique transfusion requirements which are needed in these situations. The neonatal period is defined as from birth to 4 months. Indications for transfusions of infants are very, very different, and they're based on the weight of the infant, the gestational age of the baby, circumstances surrounding the delivery, and maturation. Ill infants are the most transfused patients in the hospital if you do have a neonatal intensive care unit. Iatrogenic blood loss is carefully monitored. Do you remember what that means? Iatrogenic blood loss is blood loss due to procedures like phlebotomy. So every time an infant's blood is drawn, it is noted in the baby's chart. And once it reaches a significant level, the order to transfuse will be given. And again, it's based on a variety of different factors that we just discussed. The transfusion service must provide specialized service. Number one, we want to minimize donor exposure if possible, because we know blood transfusion is not without risk. Use one unit with satellite bags is an option, and I've done that before. Or we use a sterile docking device that a unit of blood is assigned to an infant, and we're able to aliquot the blood as needed. The sterile docking device is the coolest machine that was developed during my time in the transfusion service. So if you look here, you can't really see, but on the left, there's the original bag of blood. And on the right, there's the aliquot bag. You can see it just barely on the lower part of the platform. So what happens is the tubing's inserted into the device and welds the two together. So now we have a single tubing that's now open, but the system remains closed because it's done in a sterile manner. We then squeeze over and weigh out the amount of blood that the doctor ordered, and then we heat seal it back together. And we snip off and take that aliquot to be given to the infant. Meanwhile, because that unit has not been entered or opened, it maintains the original expiration date. And if you remember, once a unit is entered, it has a 24-hour expiration date. So this allows us to use a single unit for a long time, whatever the expiration period of that donor unit is. Fetal and neonatal erythropoiesis is very important for you to understand so far as dealing with infants in transfusion. Appropriate transfusion practice requires knowledge of neonatal physiology and careful clinical observation. As the embryo develops, the predominant sites of hematopoiesis changes. At about the 9th week of gestation, it shifts from the wall of the yolk sac to the liver. And at about the 24th week, midway through the pregnancy, it shifts from the liver to the bone marrow. Hematopoiesis is regulated by gradually increasing erythropoietin levels, and it's stimulated by low oxygen tensions during intrauterine life. The environment in utero is totally different than once the baby is born. And again, where is erythropoietin produced? It's produced in the kidneys. So there are certain elements of all courses that, again, come together, and you need to remember for the rest of your professional life. At 40 weeks, which is considered full term, normal infants have a cord blood hemoglobin of 19 plus or minus 2.2 grams per deciliter. Isn't that amazing? That is so high. Think about what your normals are for children versus men and women. That is the highest level of hemoglobin you will have in your entire life is at birth. Neonates of lower birth weight have lower normal hemoglobin levels because they haven't been able to build that up to that yet. Very important for you to know that fetal red cells have a lifespan of 45 to 70 days. How long does a normal adult red cell live? About 120 days. And in the fetal red cells, at the time of birth, about 53 up to 95% of the hemoglobin is hemoglobin F. And what is unique about hemoglobin F is physiologically adapted to low intrauterine oxygen tensions. So hemoglobin F has a high oxygen affinity, which allows the red cells to acquire the oxygen from the maternal red cells throughout pregnancy and then release it to the tissues in utero. This high oxygen affinity, unfortunately, results in poor tissue oxygenation after birth. So in utero, hemoglobin F, we want that oxygen to bind in that lower tension, and then it relatively easily gives up the oxygen in the tissues of the fetus. But after birth, this becomes a detriment because the hemoglobin F binds so tightly, it's stingy. It doesn't want to give back the oxygen. And it does, and that's why babies are born with a 19-gram hemoglobin, because the more red cells are there, even though they're stingy about giving up their oxygen, they then have an adequate supply. Hemoglobin A replaces hemoglobin F after birth, and again, the transition starts towards the latter part of the pregnancy. Oxygen delivery to the tissues remains satisfactory despite a physiologic fall in hemoglobin concentration. And then the oxygen dissociation curve shifts to the right, which then will reflect improved oxygen delivery to the tissues. So premature infants have lower hematocrits and a greater percentage of hemoglobin F in their red cell than term newborns, which again, a lot of times you will see babies on oxygen who are born prematurely because they're not able to compensate adequately at that time in their little life. After birth, as tissue oxygenation improves, erythropoietin levels declines and erythropoiesis diminishes. This decline in red cell produces a physiologic anemia of infancy. And for those of you who have had children, at your 12-month well check for your baby, they will do an anemia screen because some babies don't bounce back. Most, over 95%, will bounce back, but some just can't kind of get up to snuff and getting that increased erythropoietin, increased red cell production. So again, the decline is called the physiologic anemia of infancy, and this occurs, that's why the babies are tested at 12 months. Normally developing infant maintains adequate tissue oxygenation despite lower hemoglobin levels. And they're not doing much that requires oxygen. I mean, they just lay there like a little ball versus a toddler who's running 90 miles an hour. So it all works out. Unique aspects of neonatal physiology. The differences between newborns and adults dictate the differences in transfusion practice. Newborns are small and physiologically immature. Those requiring transfusion are often premature, they're sick, and they're unable to tolerate minimal stresses in their environment. Infant size, full-term newborns have a blood volume approximating 85 milliliters per kilogram versus premature infants whose average blood volume is 100 milliliters per kilogram. So again, the earlier you're born, the more hemoglobin F you have, the tighter you hang on to that oxygen. So you need more red cells to maintain adequate tissue perfusion. The survival rate continues to improve for infants weighing less than 1,000 grams, which is 2.2 pounds or less at birth. And because of that, the transfusion service must be able to provide blood components for patients whose total blood volume is less than 100 mLs. And that's why I have frequently transfused 10 milliliters of blood to a baby, because once they've lost 10 mLs, that's 10% of their blood supply. And so, again, we need to be able to prepare these uniquely small aliquots to bring their blood volumes back up to normal. Small blood volumes and need for frequent laboratory tests makes replacement of iatrogenic blood loss the most common indication for transfusion in these sick newborns. Infants do not compensate for hypovolemia very well. What does hypovolemia mean? Low blood volume. For them, it will result in diminished cardiac output. It affects their heart, and it results in poor tissue perfusion, the ability to get oxygen to those tissues, low tissue oxygenation. The tissues, because they're not getting enough oxygen, they lack oxygen, and then that can lead to metabolic acidosis. Bone marrow responds more slowly to anemia. In a normal person, the trigger is the oxygenation decreases. That stimulates your kidneys to produce erythropoietin, which then stimulates the bone marrow to produce more red cells. But in these babies, they don't know how to do that yet. They're just not real good about it. And if we top it off with hemolysis due to a maternal antibody, there may be no increased erythropoiesis for 2 to 3 weeks. And what I found in my experience is the more preterm the baby, the more frequent the transfusions. Cold stress, also called hypothermia, causes exaggerated effects. It increases their metabolic rate because they're trying so hard to keep warm. Hypoglycemia, because they're trying so hard to keep warm, the blood glucose goes down. Metabolic acidosis is where you're converting the glucose to sugar, and then the byproducts of that. And then tendency to apneic episodes. Apneic episodes is when the baby quits breathing. And this may lead to hypoxia, hypotension, low blood pressure, and cardiac arrest. And if you've noticed, if you've ever visited a baby in the nursery, or they have these little caps on, and the caps are, the most heat is lost through the baby's head. So they usually put these little knit caps on to help babies maintain warmth. And in the neonatal intensive care unit, the NICU, they're in a warm bassinet, always. Blood for transfusions should be warmed if given in large amounts. Small amounts reach room temperature in about 20 minutes and does not need to be warmed. So by the time the nurse comes to the transfusion service, they pick up the blood, they get up there, they do all their checks and balances and whatever. It's been 20 minutes, and it's safe to give that blood not warm. But if you're giving 30, 40, 50 mLs of blood to an infant, it needs to be warmed. Infants are immunologically immature. The antibodies present in their plasma originate almost entirely from maternal circulation. IgG is the only immunoglobulin class that crosses the placenta, and this passively acquired antibody from the mom across the placenta into the fetus, now baby, is conserved during the neonatal period due to the slow catabolism by the fetus. But there are limits. Usually by 3 months of age, the immunoglobulin levels have decreased almost to nothing, and the baby is supposed to start growing up already and making their own little antibodies. Infants exposed to an infectious process in utero or shortly after birth may produce small amounts of IgM detectable by sensitive techniques, but they rarely form RBC antibodies of either class during the neonatal period. What is the definition of neonatal period? 0 to 4 months. So during that 4-month period, the testing that we do is really different than what we do for adults because babies do not make antibodies against red cell antigens. Transfusion-associated graft versus host disease is a major concern, and it's been reported in newborns receiving intrauterine transfusions followed by postnatal exchange transfusions. What is graft versus host disease? So if you remember back to serology, passenger lymphocytes are given during the intrauterine transfusion. So again, when we prepare a unit of blood, we spin it down, we remove the plasma. We have the red cells in the buffy coat. In that buffy coat are lymphocytes. So again, during transfusion, these lymphocytes are passively given to the baby. And these may have induced host tolerance so that the lymphocytes given in subsequent exchange transfusion were not rejected in the normal way. And then these engraft in the baby and recognize, oh my God, this is not my body and I don't like it. And they start making antibodies against the tissues of the infant. And so this is transfusion-associated graft versus host disease. GVHD is not felt to be a significant clinical problem for immunologically normal newborns who receive multiple exchange transfusions. And that's a new word, exchange transfusion. That will be defined later on in this series of lectures. So how do we solve this problem of transfusion-associated graft versus host disease? We irradiate. And irradiation of blood kills immunologically competent lymphocytes. Irradiated blood is given to low birth weight, low gestational age, or septic premature neonates. Such infants are immunologically more vulnerable to TA-GVHD. Blood for intrauterine transfusions? Yes. We can transfuse a baby while it's a fetus, while it's still in its mother. The blood must be, it says should, but must is a better word, unless you absolutely cannot find an irradiated unit. Any directed donor blood from a relative should be irradiated. I've had many times where parents, oh my God, what can I do to help my baby? And the dad wants to donate his blood to be given to his baby. Number one, you have to be ABO compatible. And that's not always the case. So that kind of gets us off the hook. But they don't understand because they are so genetically similar to their child that if we transfuse that child with his blood, then if passenger lymphocytes, viable passenger lymphocytes are present, then this could result in graft versus host disease. So again, all blood that we give to infants in the United States, unless it's absolutely not available, must be irradiated. Metabolic problems. These babies have immature kidneys that have reduced glomerular filtration rate and concentrating ability. The newborns may have difficulty excreting potassium, acid, and or calcium loads. Acidosis or hypocalcemia may also occur post-transfusion because the immature liver metabolizes citrate in bank blood inefficiently. So everything that's present in the blood is again transfused into the infant. Because their kidneys aren't mature, this may result in additional problems due to those chemicals being present. Studies have shown older units do not affect the infant for routine transfusion purposes. We're really talking about massive transfusions. In the case of an infant, could be 50 cc's of blood. 2,3-diphosphoglycerate, also known as 2,3-DPG, is concentrated in the center of the red cell and binds to hemoglobin. Again, a reminder, tissue oxygenation in newborns or in the fetus are poor due to the high percentage of hemoglobin F. And hemoglobin F does not release oxygen to the tissues like adult hemoglobin. Like I said, it's stingy. Respiratory distress or septic shock have decreased levels of 2,3-DPG. Alkalosis and hypothermia can further increase the oxygen affinity of hemoglobin. So these are issues for the physiology and the oxygenation of the newborn. On the blood bank side, 2,3-DPG levels decrease in stored blood. And you need to recall the lesion of storage in stored blood because this becomes crucial in transfusing neonates. Newborns for a large volume transfusion should be given the freshest blood available, less than 5 days old, because the 2,3-DPG levels are the highest. The controversy in the field about the practice of using fresh blood is it of greater importance to decrease donor exposures rather than give fresh blood. Allow CPD donor units to be put on hold for infants for 21 days. So this reduces their risk of exposure because we're only using that one donor for them. And the exception is for massive transfusion. So this is pretty much accepted practice in all neonatal intensive care units, that the primary concern is reduced exposure of donors versus fresh blood. And 2-3 DPG levels return to relative normal levels within 24 hours of transfusion. Cytomegalovirus bring immunology serology back to the front of your brain. An infection by CMV may occur in the perinatal period, either in utero or during birth, by breastfeeding, or by close contact with mothers or nursery personnel who carry the virus. CMV may also be transmitted by transfusion. The virus seems to be associated with the leukocytes in blood and components. Infections in newborns is extremely variable in its manifestations, ranging from asymptomatic seroconversion to death. We had a set of twins born. They were fraternal twins. They both got CMV. One recovered, one died. It's just a very variable clinical course with this virus. Symptomatic infections may produce pulmonary, hepatic, renal, hematologic, and neurological dysfunction, so devastating consequences to the newborn. So this is a newborn with a severe CMV infection. They were found to have respiratory distress, an extensive rash, and hepatosplenomegaly. And I want you to know that term, hepatosplenomegaly. Hepato, liver, spleen, megaly, enlarged. So they have both an enlarged liver and spleen. The results of the CMV antibody test, both IgM and IgG, were positive, and plasma DNA polymerase chain reaction assays were also positive. So epidemiology and prevention of post-transfusion CMV in neonatal patients, in babies, have been under intense investigations, and the following observations have been noted. Where the CMV rate is high, symptomatic infection is low. Babies of seropositive moms are unlikely to develop CMV because what happens to those maternal antibodies? They cross the placenta and protect the baby or the infant or the fetus. Premature infants born of seronegative mothers, weighing less than 1,200 grams and requiring multiple transfusions, are at high risk for symptomatic post-transfusion infections. The risk of CMV increases with the number of donor exposures. And again, all transfusion-transmitted diseases are possible. So by limiting donor exposure, we will decrease the chances of the infant acquiring CMV. The risk of transmission decreases by using, number 1, seronegative donors, and number 2, components depleted of leukocytes. And again, we bring back the processing of blood. First thing after a unit of whole blood is collected, it goes to the back and is put through a leukocyte filter. And it removes 99% of the leukocytes in donor blood. So boom, right there we've really significantly decreased the risk. And then we test all donors for CMV antibodies, and we only transfuse our babies with those donors who are CMV neg. The AABB standard states that in geographic areas where post-transfusion CMV transmission is a problem, blood with minimal risk of transmitting CMV be used for newborns weighing less than 1,200 grams, newborns born to mothers who lack CMV antibodies or whose mother's antibody status is unknown. So again, most blood banks make it standard practice to transfuse all infants with CMV negative blood, regardless of their weight or term. This is the end of Unit 11, Part 1.